Hello to the technical person. Elizabeth, who's I'm going to be interviewing for my segment, has been on the line for half an hour or so. And she's not getting in the room, and I don't see her as a participant. You're getting on now?
Hi, Tracy. Can you hear me?
Yes, I can. Hello. Hi.
Can you see me?
Yeah, I can see you winking at me in your picture. Yes.
Oh, okay. Can you?
You're not live. You're not. It's not a live image.
Oh.
I've got your portrait.
Okay.
So I just promoted Elizabeth to a panelist, so that should do the trick.
Okay.
Oh, I've been promoted to a panelist.
Yes. So I see your name here. And here you are live.
Can you see me live now?
Yes, I can. Your camera needs to be a touch higher, maybe, to see more the other way.
Better?
The other way. Yeah, that's nice.
Is that better?
Sun, yes, it's wonderful. You've got sun screaming in your window.
Yes.
How are you?
I am great. How are you?
I am good. I'm good. So thank you so much for being with us today and for supporting our efforts to, squash, kill any violent word you want to use to deal with Bill C7.
Smash, destroy.
Yeah.
Ameliorate. No. What's another good one?
The opposite of ameliorate.
What's a good one? How about destruction?
There we go. There we go. So
yes. Okay. Yeah.
So, Elizabeth, I'm going to let you introduce yourself, and for this segment, you wanted to interview me for some things.
Yeah, so I am really excited to be here today. My name is Elizabeth Mohler, and I am a board member with Citizens with Disabilities Ontario. I'm a member at large, and I've been involved with the organization for about a year now. So I'm a newbie to this scene, but not a newbie to disability. I live with a visual disability myself, and I support two nonverbal family members who live with a disability as well. Also, I am doing my PhD at Western University in health and rehab science, and I'm looking at direct funding, attendant services policies, and how those policies shape who does and who does not have access to services. So I thought it would be really interesting today to interview Tracy a little bit about healthcare and ableism in healthcare, and talk about some of the things that present as challenges to us as people with disabilities when accessing healthcare, in the hopes that, again, we can shed light on how problematic this bill is and the need to really reduce this bill to ashes. There, that's a good one. Okay.
That is a very good one, yes.
Reduce it to ashes. Okay. So to kick us off, Tracy, maybe you can just explain kind of what does it mean when we say healthcare is an ableist practice or ableism in healthcare?
Well, think about what medicine is all about, right? It's about a person who is sick. So in other words, that's a departure from a state of being, right? That people would think would be ideal. So let's call it like a healthy state. The medical profession is all about thinking about a person in terms of illness and sickness and ways to restore a person back to health wherever it is possible, or if not possible, to do whatever treatment is available to bring the person as close as possible to that vision or ideal of being, I guess, typical, maybe, so because of that, it's ableist, because by definition, is trying to bring somebody up to a certain standard. So, like, I'm thinking about, my childhood growing up, as a child with a disability, a child who never walked. And I went to live in an institution in order to get services that were not available in the community. In order to get these services, you had to reside in the hospital. And in the hospital, I met children, like I was with 48 other kids with disabilities, some of whom could walk, some of whom were in wheelchairs, some of whom could talk, some of whom use letter boards or other ways to communicate. Um, and it seemed to be that if a kid was in a wheelchair, they wanted to get them walking, like that was the goal. And sometimes they'd be walking, on crutches, braces and crutches, or they might have like some kind of a walker thing that they pushed around of some sort. But it was considered better if you could walk than if you couldn't walk. So that was sort of a step that they were going to. It was considered better to be able to try to talk verbally, rather than use, a device to talk. Like, so like everything was about trying to appear normal. So there were kids who had multiple surgeries just to get their legs straight enough to put them in braces so they could stand up. So, kids went in the hospital, had like, multiple times going, under anesthetic, having surgery, dealing with the pain of the surgery afterwards, being out of school for the time that they had the surgery and rehabilitation or whatever therapy they needed afterwards. And the goal was so the child's legs would look more normal, right? Like their legs would just be straighter and whatever. And if the child couldn't walk, that was kind of considered like a failure, of the system, that they couldn't get this child to walk or even appear, normal. So a friend of mine who is still a friend, that I grew up with when I lived in this institution, she went out to school, for starting in grade 6. She was able to go to a regular school. And she had to wear these braces that were like, locked at the legs and locked at the hips, so very rigid, standing there like a little toy doll, and her a crutch in each hand. And then she'd have to push herself up on her crutches and then swing her legs through. And like, so that was like her way of walking. And she'd have to carry her books in a backpack on her back. So she couldn't carry anything in her hands because her hands were busy hanging on, right? And her school didn't have an elevator, so she had to go up and down the stairs to her class. And so she was always a little bit nervous about getting bumped by a kid on the stairs because, kids are kids, and even adults, people are people. And, so she had this kind of anxiety about getting tripped or pushed over. I don't recall her saying sorry of anybody like making fun of her for the way that she walked, because it was obvious that she had braces and crutches, and so, she wasn't made fun of. But another young boy who went out to school at about the same grade, he could walk without crutches. His legs were a little bit, how shall I say it? Like his legs were kind of bowed, like as if he was had ridden a horse all his life, So he had kind of a way of swaying, kind of a really cool way, I thought, of walking around. But kids made fun of him because I guess he sort of looked normal, but he would have this weird way of walking, and kids thought he could control that or do it differently. He was the only person they probably ever saw who walked in a different way. And like, so he was kind of bullied at school, and he didn't want to go out to school. He wanted to come back to the school at the hospital, so this is part of, all this ableism thing and, pushing people to be, in look a certain way and to look
Yes.
as typical as possible. So
Yes.
a little later, when my friend was able to make a decision, like she was going to use her wheelchair at school and not braces and crutches anymore, because now her school was accessible. There was an elevator, so she could use, she went to high school, so she could do that. Like how liberating it was, because she could whip around, she could do wheelies, she could show off, she had her own set of skills and talents that she could use. It didn't matter how many books she put on the back of her chair, it didn't matter.
Yeah.
And her hands were still free. She had to wheel her chair, but she could still, manage to carry things on her lap or one hand at a time and switch, for hold your cup in one hand, wheel with your other, and then switch,
And it reminds me of how, like, we really try, as a society, silence conversations around our devices and our personal care needs because it's uncomfortable or there's stigma associated with it. But from what you're saying, and I would agree with you, these devices can be quite liberating. A wheelchair that allows somebody to get around and be in the community, or a computer with speech software. But I think there's a tendency to have silence around these conversations or to associate stigma with these devices. And it sounds to me like, from what you're saying, it's like, hey, these devices are actually pretty cool because they allow people to do things that might just do them a little bit differently.
Yes, yes.
Yeah. And so one thing that I was wondering about, because I don't know about you, but I've done a lot of reading around, healthcare and how people with disabilities, especially during COVID, are being treated if and when they go into hospital. And I know, as somebody who lives with a disability, I do not want to be in a hospital right now because I'm terrified I wouldn't have the supports I need. Even as someone with vision loss, getting around a hospital by myself could be difficult, knowing how to fill out the forms if they're in print. And so wondering if you have any thoughts or comments just around that kind of piece around COVID and the lack of supports that we've been able to bring in with us and what impact that's had.
Yes. I'm going to just go back a little bit. A couple of years ago,
Sure.
On top of my disability that I was born with,
Time travel is fun. Let's go back a few years.
Well, but I had a stroke. So that's kind of quite sudden. You just can't pick your time, right? It just happens when it happens. Luckily, I was on my way downtown at the time, so I was very close to the hospital that I normally use. And in the hospital, I went. I was in intensive care for a day and a half or so. I was unable to talk at all. I understood what people were saying to me. I was able to sort of indicate yes or no to certain things. So I was asked if did I want to have this procedure done for my stroke, which had I think a 9% chance of clearing the block out entirely, or a 9% chance of killing me, or any in between, any varying degrees of eliminating the stroke. So, because it was risky, they wanted to make sure that I understood the risk of, doing it. So I said, okay, I nodded yes to do it. So I was very grateful that the doctors who were attending me in emergency could figure out very quickly that I knew what was going on and that I could make that decision for myself, because otherwise it would have been left to my husband or my daughter to make that decision. So just by comparing with pre-COVID, in the hospital, unable to talk, my family rallied the supports around me. So I had pretty much 24 hours, one of my attendants who knew me with me in the hospital. So these were people who I'd already trained at home. They already knew what positions I'd be comfortable with. They already knew how to turn me without hurting me. They already knew, like, how to do various things. And as I recovered, I was able to sit up and talk and get in my chair. Like, they knew how to use the equipment to transfer me to my chair and sit me comfortably so that I can function and move my arms. So all that stuff.
Just want to stop you there because you've said something I really want to pick up on, and that is that you trained your attendants. And so one of the things I'm wondering is, do you think that that's a really important piece of being able to direct one's own support needs? Because I know that there's a lot of people with disabilities who just have the luck of the draw. Whoever comes in, they receive PSW training or nursing training, and there's not a lot of room for sort of that self-direction piece. I wanted to pick up on that before you move on.
Yeah, for me, it's very important because I do things in unconventional ways. So the time before, when I was in the hospital, which was like decades earlier, when I had my kids, a nurse came in because I had to go to the bathroom. I needed help to go to the bathroom. And I started to explain to her, how to roll me so that, she could put the bedpan underneath me. And she's like, oh, well, I know how to help a patient with a bedpan. Like, I'm a nurse. You don't have to tell me. I'm like, oh, okay. So I'm gonna just play along, right? So she's like, okay, lift up. So what she meant was, I'm on my back, use my legs to like prop my pelvis up so she could put the bed. And I'm like, so I have spinal muscular atrophy type 2. I've never been able to do that maneuver in my life. And she went, oh. And I said, now would you like me to explain how I get on the bedpan? She goes, okay. So I talked her through it and we were fine. And then the next time she comes in with another nurse, she's like, she will tell you everything you need to know. You just listen to her. So suddenly I had an ally with this nurse who at first wasn't prepared to listen to me because she felt she knew everything. Finding out that sometimes when you have a disability all your life, you've had to figure out a different way, of doing things. So it was very important for me to have my attendants. Like, I felt I might die or be killed accidentally in a hospital if people didn't know. So they might turn me and think I'm fine and then rush out of the room without checking. And meantime, they could have turned me with my face into the mattress where I couldn't breathe properly or something like that, right? So I worry about those kinds of things, or not getting moved, and then you're in pain because I can't really move myself at all. It's like being like, I don't know, having Elmer's glue on your back and being pasted on, like I just can't move myself, right?
And it reminds me of so many of the stories that we've heard on CBC and other networks about what's happening in LTC, and it goes back to the same issue. People don't have their support people with them in the trenches advocating alongside, and so needs aren't being met. And unfortunately, we've seen what's happening. And so I do want you to continue your story, but I just think it's really worth mentioning that this is a huge problem right now during COVID, and a lot of people are struggling with this.
Well, and we've known for a long time, the disability community certainly has known, nursing homes are not the place we want to be. Nursing homes will kill us accidentally, or probably, deliberately, for too vocal and, annoying. But it's a very dangerous place for us to be. Hospitals are a very dangerous place to be. The first order of business is to get out of there as quickly as possible. But if you have to be there to have supports of people that and who can advocate for you, because sometimes they want to do things and you need an advocate to say, no, like, that is not possible for this person to do. So I had that whole system. I was in the hospital for about 8 days before I was released to come home and finish whatever recap I was going to have from home. And I had that support, as I say, like almost 24 hours. And if an attendant wasn't available, my husband would be there, or my daughter would be there. Like, somebody was there. who could help me or vouch for me or, make sure things were followed up on. So another thing that was an issue in the hospital was I couldn't work the call button. I didn't have enough strength in my hand to push the button when I needed help. So you're, you're, it's very dangerous if you can't like let people know that you need something, because you're just depending on them. They're just wandering the room whenever, and then to be able to get their attention and say, what you need. So apparently was some kind of switch that was very easy to work. It was like a little paddle. I just had to touch it anywhere. And there was something, and one of the OTs, knew about it and dug it out of the back closet somewhere. But my daughter just kept on them, like a dog with a bone. She just kept on them until I got this thing that I needed, because he was my attendants there. They might step out to go to the bathroom. They might step out to go get a meal, or, for whatever reason. They might step out of the room, and that might be the moment that I needed to call someone for something, important.
Yeah.
So,
and that's really scary. And it's so interesting as you're sitting here talking, I'm thinking, but whoa, wait a minute. Shouldn't, of all places for people with disabilities, we feel safe in hospitals, but no, we don't, for all the reasons you're mentioning. And the call bell one is one I've heard before, and it's really, really scary. So wondering if you can fast forward a little bit. We're going to go ahead in time now to talk to us about last summer, when you unfortunately did have to go to the hospital, and what that was like during COVID. And this was during the time, just for people listening on the channel today, where the bill had not passed, more than the hashtag more than just a caregiver, or sorry, more than just a visitor, was passed, but that had not yet been passed. So that's kind of where we're at in terms of the time frame. So the caregivers, essential caregivers, could not at this point come into hospital.
Yeah, absolutely. And like when COVID came up, and I realized, oh my God, if I have to go to the hospital, like, they're not going to allow people with me, like I'm going to die a slow, painful death there, because they're not going to be able to come and, turn me or do anything for my comfort, let alone things that might be life and death for me. So I'd already decided if I got COVID, I was just going to stay at home, do whatever I could, probably die, but I wasn't going to go to a hospital. So here I was in an emergency, and I had to have an emergency scope done of, they go through your mouth down to your stomach. They were checking for me having a bleeding ulcer, which they suspected. So when I went to the hospital in emergency, my husband was with me, and I said, I really need my husband to be with me, in emergency.
Sure.
And so they said, okay, so he was allowed to be with me the entire time in emergency. And it was, really important, because they wanted me to transfer onto a gurney, I guess you want to call it, like a stretcher kind of bed. But they didn't have the lifting equipment or anything, in an emergency to lift me. And I use a different kind of what they call a sling, like the thing that's under a two-piece one. So it goes under my knees and it goes around my back. And I hang there, from my armpits to my knees. I'm just hanging there. But I don't fall out of it, which people are going to think I will, but I don't fall out of it. Anyways, there's another way that I can transfer onto a bed that my husband knows how to do. And so it was good that he was there, because he was able to get me on the bed, get me comfortable, like find extra pillows to prop me this way and that way, whatever. So then they took me to go get the scope done. He was allowed to come down the hall with me, not into the surgery area, which is typical. And the anesthesiologist was great. He explained what he was going to do. I explained my concerns, because having anesthetic with my disability, when you're weak and maybe your lungs don't work, I want him to understand all of this, which he did. And then they put me under for the procedure. And yes, indeed, I had a really exciting bleeding ulcer. I would have bled to death. If I hadn't gone there, I would have bled to death.
Wow.
So they were able to cauterize that, seal it off the bleeding. And then after I came to you and my husband was there, he's like, okay, so now we want to admit you for 5 days because you need an IV intravenous for iron because my hemoglobin was very low as a result of all the blood that I had already lost. And so what they normally do is they give you an IV to get your hemoglobin up, very quickly. And I said, well, I don't want to be admitted to the hospital. I'm, worried that I won't have the support that I need. He's like, I'll make sure that you have everything that you need. Like, don't worry about it, but you really need to be admitted to have this IV. And I said, well, can I not do this at home? I know I've seen people in the community with IV, things hanging off their chairs. And oh no, we have never heard of anyone doing this at home. So the doctor said, no, this cannot be possible. So anyways, off I go to be admitted up to the ward, and my husband was allowed to come with me while I was admitted. And then he went home to get my stuff, like my charger from a wheelchair, for instance, and like my slings that I use for transfer, like whatever. He went to get some stuff. And when he came back, they wouldn't let him back up to the ward.
Wow. That was a scary moment.
Yeah. So, here I was with my cell phone, rapidly running out of power.
Oh, wow. I can't imagine.
And he's like calling me saying he's downstairs and they wouldn't let him come up. And, but he had my stuff. So one of the nurses said they'd go down and get the stuff from him. Here I am. So I'm in my chair, but I can't work the call bell. I can't get their attention. But they said they would be like able to hear me and they would come if I needed anything. So I started to need something. My arm was starting to fall off my armrest, and I thought, oh, okay, I'm gonna just give them a call. And so I started calling at like it was 20 after the hour, and it was like a 10 to the hour before somebody like came in, because I could call verbally, but it was like a long time before they came in. I'm thinking, I've got to talk to these people about how to get me on the bed. And once I'm in the bed, like I'm not going to be able to call as loudly, because at least I could drive my chair like near the door. Like you weren't supposed to you weren't supposed to go outside your room, right? Because of COVID. So I couldn't go down the hall and get them at the nurse's station. I just kept trying to call them, and I was testing, to see if it was going to work. And they didn't hear me. They didn't come for a very long time. And I thought, if I'm in bed and I'm having trouble with my position that I can't breathe very well, I'm in danger here. So I called David and I said, I'm going to go home. I'm not going to stay. So when the nurse came, I said, like, I'm leaving. She says, you can't leave. I said, yes, I can.
So just stop there for a minute. So maybe people don't all know this, but can we leave a hospital or a facility if we're not feeling safe? Because people may not know that that's even an option.
I did not feel safe and I left. They call it, they say you're leaving against medical advice, AMA. They have a short form for it. So it must happen often enough that they shortened the term, right? So I'm leaving AMA. And they're like, you can't leave against medical advice. I said, I can leave and I'm going to leave. I don't feel safe. Well, why don't you feel safe? Because you can't hear me when I call for help. Like I don't feel safe in that kind of condition at all. So anyways, the nurse took me downstairs so I could, meet my husband. And then there was a form I had to sign, which I signed also, whatever, to get out of there, just to say that I'm leaving against medical advice. And I said to her, okay, so am I supposed to like not eat solid foods for a couple of days or something, like because they did this procedure? And she says, I can't tell you anything because you're leaving against medical advice.
Wow.
So even if she knew the answer to my question, which I don't think she did, but even if she did know the answer to the question, she would not be at liberty to tell me that because I'm leaving against medical advice, right?
Wow.
So I left and I called my family doctor in the morning and told her what happened. Or actually, I sent her an email. I emailed her first thing in the morning to tell her what had happened.
Right.
and to ask her if she had any advice for me. And so she gave me a call and gave me she told me to take a certain amount of iron every day, orally. And she talked about my, if there was any restrictions on diet or whatever, which there weren't, just as tolerated. And, so obviously there was something that I could have done at home.
Mhm.
And then later that same day, I got a call from the surgeon who did the procedure. And he says, I got a call from your family doctor. And I says, oh yeah, she's great, isn't she? He goes, in all my years of practicing, he said, I've never had a family doctor call and ask me questions. So she had
That's
actually
incredible.
called around and asked a few people, what should I do since I was at home? What should I do? And he said, what she recommended to me was exactly what he would recommend to me. So obviously there was something that I could do at home, right?
Yeah, and that's so interesting. But another point you've raised is the importance of finding your allies. So it sounds to me like your family doctor is a pretty strong ally. And it's, I think, really important when we're well, and I'm taking myself into this equation, that we find the time to really look into a good family doctor who's going to advocate for us. And that's something I know I need to work on, because it sounds like when you have that one person in your corner, it's a lot easier than if you're running to a walk-in clinic at the last minute, you don't have a doctor and you're stressed out. So it sounds like that's been really important to you.
Yeah, and it's the luck of the draw, because I deal with a particular hospital, St. Michael's Hospital in Toronto, and they have a family practice clinic, which I've
Yes.
been a part of since before my kids were born. So
Mhm.
like over 30 years. So the doctors there come and go, but you get like a doctor assigned to you as your primary family physician. So it's
Mhm.
not like every time I go, I just see whoever is there that day,
Mhm.
right? It's not like they're just doing continuity of care based on what's in your chart last,
Right. Yeah.
which sometimes it's like that, but
Yeah.
you actually have your own doctor that you can see, and they get to know you as a person. And
Mhm.
for me, this is very important for them to advocate for me, because they have to know under normal circumstances, like I am active. I
Yeah.
have things that I do, I'm able to talk, I'm able to be reasonable, I'm able to whatever I can, you know what I mean? Like they know what I'm like. So if I suddenly
Mhm.
come there and I'm like, I'm not acting like my usual self, my doctor is going to know how that's a departure from my usual self.
Mhm.
So it's not quite like ableism. I guess in a way it is, but it's like instead of comparing me to like everybody, the norm for everyone else, she's able to think about what's normal for
For
me.
you in that moment. Yeah, that sounds really important. And I'm wondering, just to kind of bring it a little bit to Made, I attended, and you might have attended them too, some really great webinars by the DeBever Institute a couple of weeks ago, and they had three wonderful panelists. And one thing that really resonated me with this was the second panelist, Dr. Ramona Coelho. And she talked a lot about reasons why people might ask for Made. And one of the things that really struck me is that they're not being given supports to live. So they're not being offered a full chance at a quality of life. And I'm wondering if you could maybe talk a little bit about that.
Oh my God. Like I'm deathly allergic to peanut butter. And I have said to my family all my life, if it ever comes down that you're going to put me in a nursing home,
Yes.
just give me a peanut butter sandwich. You know what I
Yeah.
mean? Like,
Well,
like,
and it's so interesting that you say that, because Dr. Coelho cited one of the individuals that had requested Made, and I believe it was someone in their 20s who was living in a 30-degree room with three other people who were several decades older than her, in the middle of summer, and didn't have access to any of her stuff, and just had no quality of life and was giving up hope. And so just maybe we can kind of talk about some of the really harsh realities around that.
yes, like living in a nursing home is awful. There's no way to sanitize that. We've seen from what has happened, um, how vulnerable that population is. And, person might say, oh, well, they're old, they're going to die anyway. So they die this year instead of next year, or this month instead of next month, but that's not really the point. The point is, there's nobody there. If you need to be fed, are they going to be able to take the time to wait for you to chew and swallow? Are you going to be able to get more than a couple of bites into you, before they have to move on to go feed somebody else? Because there's just not enough one-on-one time, right? Like in a nursing home, the PSWs that are there typically will have, oh my gosh, like anywhere from 7 people to 14 people that they have to get up and ready for breakfast. So, some people need like a little bit of assistance, but some people need a whole lot. So it'll be like, they'll come back to them after they get everybody else up, and so some people don't get up at all. Do they get to eat? They might not get to eat at all. And then it's like, what is written down? Is it written down that person did not eat because we didn't have the time? Or is it written down like, oh, the person refused their meal, or the person was not hungry? Like my uncle passed away in the middle of COVID. He was in a nursing home. He had advanced Alzheimer's, but he was doing well. Like his wife, my aunt, went to see him, I think 3 times a week at least. But there were other people around. There were like volunteers around. Like there were people to keep him engaged and interested in doing things, in the facility. But anyways, when she finally got to see him towards the end of COVID, when they allowed visitors in again, so-called visitors, they're much more than visitors. They're essential, to that person's survival. But anyway,
essential caregivers.
Yeah, in the 3 months that she had not been allowed to see him, he had lost so much weight. So clearly he was not eating because he wasn't interested in eating. Like there was nobody to get him interested, nobody to anyway, he had just lost so much weight, and he died like in the summer, of last summer. And, he might not have had to die like that soon, and certainly not that way. It sounds like he died slowly of starvation and lack of stimulation. You know what I mean? Like just being in a room, imagine like being in a soundproof room if you also can't see, and then maybe a couple of times a day someone comes in for 5 minutes to do whatever it is that needs to be done, and that's all you get. And plus you've got a situation where your brain is slowly deteriorating. I mean, that's going to happen much quicker. So nursing homes are terrible places. Like they should not exist, and some countries have decided not to have them. We don't have institution for kids anymore, like where I grew up. We don't have that. We decided kids should not be growing up, in a big hospital. So we have like maybe small group homes or something on a smaller scale where you're seeing more individually, and people, can take more time to do what you need. But for me, I would never go into a nursing home. I would rather, end my life if that was all. If that was going to be my life, I would not feel safe there anyways. So I'd rather just go quickly and, I'm a planner, so hey, I can just plan when I'm going to go. But not to make light of it, but a nursing home would not work for me. And if my family couldn't cope with me at home for whatever reason, if we couldn't cope with the supports that I could bring in through the direct funding program, which we have in Ontario, you can hire your own attendants, which I've been doing for the past 16 years. If we didn't have, if that would not take the pressure off my family to do anything in between, I would request MAID under those circumstances. I would. I've got like a chronic pain situation happening, had for years and years, and it's been very difficult to keep that under control because it's getting worse over time as my spine is deteriorating. It's gradually getting worse. And so every time we get the pain medications where it's kind of tolerable, then suddenly, I need different medication or more medication, So over time, that's going to get worse. If I get to the point where they say, Tracy, there's nothing more that we can do, there's no medication that's going to work, anything we would give you would just knock you out, like you'd be unconscious, like at this level of whatever medication. And if that was going to be my life, then, under that circumstance, I might want to choose MAID. And the way the law was written before these amendments were coming in, I would have had that option, I believe, under MAID. I would have had that option. And if not, I always have a peanut butter sandwich.
Yeah.
Right.
And so I just wanted to sort of really back up a little bit, because it's a really interesting something you said, and I agree with you that nursing homes should not exist, and other countries have abolished them in favor of smaller scale settings. So in Denmark and Norway, they have, and we used to have them here after the war, they were called Abbey Field houses, where, people that needed support lived in a smaller home-like setting with staff, but they had their own private areas and then some public space if they wanted to get together with others in the house. And so I think in Sweden and Denmark and Norway, they call them nursing flats, where people who do need help can get that help, but it's in the community. And I think part of it goes back to stigma, that we don't value people who are older or disabled or ill. We put them in chronic care hospitals or long-term care homes. We out of sight, out of mind. And it took COVID for us to see how bad things were. But these problems have been going on for a long time.
Yes.
And I think part of why people are being discharged, especially younger people, into long-term care goes back to ableism. I don't think healthcare providers know about the options to live in the community. That's part of it. I also think that there needs to be more options, absolutely, and more funding. But I think the big problem really is that until we think about more options that don't involve long-term care, we're going to be in this huge issue.
Yeah, and I mean, the kinds of things that people help me with, that people that I hire, they don't have to be a surgeon to do what I need. They don't have to be a nurse to do what I need. They don't even have to be a PSW. They just have to come with an attitude that's like open-minded, and physically that they can do the things that I cannot do, right? So I mean, I'm not asking them to go on the roof and change the ceiling tiles up there, like, you know what I mean? Like, I wouldn't do that myself, so I'm not going to ask my tenant to do that. You obviously can't ask them to do anything illegal. So if I decide I'm going to be selling heroin, like, they're not allowed to help me put it in little bags or measure it out or whatever, because I can't ask them to do anything illegal. But basically, I can train them to do whatever. We did have to get an exemption with Ontario's Healthcare Act, because there's part of it that says when it comes to an invasive procedure, has to be someone that's is qualified to do it, like a nurse. And by invasive procedure, they mean like a needle, a catheter, like an indwelling catheter, an enema, like things like that, so we had to get that changed, that under direction, or like under something about like under a nurse's direction or something like that.
Yeah.
So, a nurse presumably has trained me how to do it, and then I'm training my attendant that way. Or I could ask for a nurse to come in from home care to train the attendant to do something, if I need them to do that. But like with COVID, with all the PPE and the hand washing, like, I'm responsible as their employer to make sure they're keeping themselves safe.
Absolutely.
So like, and they know about the hand washing. I've got stuff here for them. I've got masks here for them. They all wear a mask except for one person who has like too much trouble to breathe through one. It's just like, and she's been working with me for years. So if I haven't got COVID yet through her channels and networks, I shouldn't, because all our circles are staying the same with the same people that we have. So I don't need people who are trained in the conventional way, as a PSW to work with me. And that works fine. I've had people that are PSWs, and I mean, that's fine. I still have to show them my weird way of doing things. It might
Yeah,
not be the way that they were taught in school, like how to turn a person.
yeah,
It's very different if the person is, you know, usually more mobile and they're just in the hospital for like, something, as
yeah,
opposed to someone like me. It's like, I got to put my leg this way, put my arm this way, because if you roll me, you're going to break my arm if it's not out of the way, and things like that. Like I have to be able to explain, and then they have it, but they're allowed to do these procedures. If I did need a catheter, they would be allowed to do it if I trained them.
yeah,
There's a needle that I take every day, and I train them in how to do that needle. So they're allowed to do it, because to call in a nurse to do a needle every day, like I could never go out, I could never do anything else, because I'd have to be home waiting
yeah,
for the nurse, and you don't know when they're going to come. Like there's sort of like the plumber, or the Bell telephone guy. Oh, I'll be there between the hours of this and this.
And do you think that that's part of what makes people choose to move on to direct funding? Because that agency and autonomy to live life on your terms and get help when you need it is really liberating, as opposed to, well, in an agency and certainly in long-term care, I guess to quote some of the literature, state control is afforded to disabled bodies. So you get up when you're told, you eat when you're told, you go to the washroom when you're told, go to bed when you're told. So do you think that that's one of the reasons that people move to direct funding, is that autonomy piece?
Oh, absolutely. Because before, like, I've been disabled all my life. I'm retired now. I've only used direct funding for the past 16 years. So obviously I did something before that, right? And before that, I lived in an apartment. They're called SSLUs, for Support Service Living Unit.
Yep.
SSLU. So I lived in a setting like that. So I think about 16 people who all needed an attendant, and one organization was providing that service. So there was staff, they had like an apartment there for the staff to be, it was like their office lounge area.
Mm-hmm, mm-hmm.
So in between what we call bookings, the times that where we have appointments for them to come and provide service. So you pre-schedule. I was working, so I would be getting up at say 6 in the morning, and a person would be with me from 6 until 7:30. And then I have time booked for when I was expected to get home. I'd have time booked for when I was expected to need to go to bed. And then on the weekend, I would also have time booked when I needed like lunch.
Mm-hmm.
And then at these times, I would also, go to the washroom. So they choose the staff. The staff, they train the staff to work with us on top of whatever training they have. They have to hire people that are PSWs now. I'm pretty sure they're required by government to do that in order to keep their funding. So they can't just hire on the basis of attitude anymore, or not solely on the basis of attitude. So you don't have a say, but the particular service provider that was helpful to me was called Access Apartments.
Yes.
So they have a pretty good reputation for trying to be consumer centered in terms of how they organize their policies, but you don't have a choice of who's coming. So sometimes they send me someone who is like, very short, who couldn't manage to do my washroom thing the way I needed, because if someone is too short, they just can't get the leverage to get the maneuver.
Right. Yes.
And if there's more than one person, it's fine. It's like, oh, send the other person to help me go to the washroom. But it's not fair to the one staff that's always getting called to do the stuff that's harder.
Yeah, for sure.
So the other person like making me a cup of tea and helping me with my making my lunch, and maybe folding up some laundry. But the washroom piece I have to, which is more physically demanding, would go to someone else. And so I'd end up asking my husband to do it, and or I'd come home and I'd miss my booking, because with Wheel-Trans I'd come home late, so I missed my opportunity for dinner. And although there's staff in the building 24 hours a day, it sounds like you've got access to service 24 hours a day.
We really don't.
Well, you don't, because other people are booked for service.
Yeah.
Right? So I don't have one person just for me. I'm sharing that with, 8 other women. And sometimes, a couple of guys, depending on what they needed and who was free to help them. So eventually we just decided we were going to take the plunge and buy our own home, which we were in a position to do because both of us, my husband and I, were both working full time. So, it's made me nervous, to do that because you feel like you don't have
Wow.
that safety net,
Yeah.
and but because of my husband and living with my husband, I felt like secure to do it. But
Yeah.
so part of it was really that I didn't have a say about who was coming to help me. And then if they say if the staff booked off, because staff would have sick days and holiday times and whatever else. So if a staff booked off and they couldn't get one of their own people in there to do this shift on a relief basis, they would call an agency. So you would just get
Mm.
some person
Random
coming
person.
in
Yeah.
who, probably had a PSW, but not something that I had been able to show, like, here's how you help me get on the bedpan. I
Mm-hmm.
need someone to show them. I want some there when they've tried it the first time themselves, to make sure that they didn't get hurt, make sure that I didn't get hurt, or that, I didn't fall, because if I fall, I'd probably land badly and break something. So it just became like so much that I was asking my husband anyways. I thought, maybe I will just do this. It's extra work, right? Because you're administering it yourself. You're not paid to administer the program yourself. It's one of the things that makes it more cost effective.
Yeah. So
But
it sounds like there's a lot of invisible labor or invisible work taken up by people who manage direct funding because you're doing your own hiring, training, onboarding, bookkeeping, all that yourself. And so it sounds like it's sort of a trade-off. Like, certainly you have a lot of freedom, but it does sound like there's a lot of responsibility on your shoulders.
there is responsibility. What I can say is, after you've been doing it for a year or two, then it's easier because you know what you're doing, right? Like I
Yeah.
was on a bit of a learning curve. The bookkeeper that I found, she was doing it for another person as well. And now she actually, I think she's got like over 20 people on direct funding that she's supporting for the bookkeeping. So she can really assist and make things easier. And there's times where, with the COVID top up that was given to staff, the extra $3 an hour, and then was $4 an hour before that. But she figured out a simpler way of sending the documentation to the Center for Independent Living in Toronto, who administers it. But
Yes.
a simpler way of doing it that was less labor intensive for us, like the consumers, and gave the assurance that the money was going where it was supposed to go, right? Like I wasn't taking this extra money and putting it into my own PPE or deciding, oh, I'm going to try and like leave the country for a while and go somewhere else, right?
Yeah.
Like, just to make sure you're using it for the intended purpose. And so I was really lucky to get a good bookkeeper. So now I've sort of got it down. There's some extra things that I do that I'm not required to do, but like for instance, I will do my staff timesheets. I have it on a computer, on Excel. And then when there's a change, I put the change in, and then I just have to print it for them to sign off. Whereas normally you just give people a blank timesheet and then they fill in their hours themselves. So I started out doing that. And then some people, their handwriting is messy,
Yeah,
hard to
for
read.
sure.
And if they came a couple of minutes earlier, like they break down the earlier time, but their shift is for a certain amount of time, say 2 hours. So if they wrote down that they were here an extra 15 minutes because they got here early, like there's things like that. So I wanted to clarify when they're here on paid time or not. Like if they got,
for sure.
if they're coming early because of the way the bus schedule lands, it's like, come in, relax, you're not, don't worry about it, or, that kind of thing, so that it's clear. I don't want to be taking advantage of someone who's consistently early and they're not getting paid for those hours, because over the course of a month that could add up, but to get back to your question, yes, I was able to hire my own people. You develop a rapport with them, you develop a relationship with them. Before we were doing this segment, I was talking with my attendant, Marianne,
Yes.
and you do have that relationship. So when COVID came up and I'm talking to staff, like, what are you going to do? It's like, Marianne's like, I'm not going to leave you, like, no matter what, like, I'm going to be here. If I got COVID, she's going to be here. She's going to wear her booties and a gown and a mask and a shield and everything else. I've got everything in my basement that I'm going to need. I'm ready for like the zombie apocalypse.
I'm coming to you, Tracy. If there's an apocalypse, I know where to go.
Yeah, come see me. But anyways,
wow.
She's not going to leave me. And then I've got like another person, who was like, she has signed up she told me she just started working for me and made some commitments around shifts. Mm-hmm. And we had talked about like COVID and ways to do it safely, that we both could feel safe and comfortable. That was all working out. And then she needed serve. And she's like, she didn't want to not work with me because it would interfere with her serve, but it wasn't enough hours that it would match what she would have gotten on serve.
Yeah.
So anyways, she says, like, you know what? I made a commitment to you. She says, I will come and help you, but on a volunteer basis.
That is beautiful.
And I thought, oh my gosh, like, I didn't even know this person. Like, this is a brand new person. And she's just the type of person, she made a commitment. She didn't want to let me down, but because of CERB, it would have impacted her ability to do that. And so I don't think she's doing anything illegal if she's helping me out on a volunteer basis.
Yeah, and so I guess, I'm just looking at our time here and we're really rolling along, but I did wonder, sort of just to wrap up, to bring everything back together to healthcare, to MAID. Obviously, we want the bill dynamited, destroyed to dust and ashes. But I guess, what is the one thing you would say to the policymakers, to government? What do we need? Maybe there's a couple of things to really make sure we have a quality, rich, textured life.
What do we need to have a quality,
rich, textured life?
Rich, textured. Oh my goodness. Well, first of all, what anybody else needs, because we're all human beings, right?
Yeah.
So we need to feel safe. We, need to be in a loving relationship with, I think, at least one person in your life, who's not paid to be with you. Mm-hmm. I think we all need that. However, we define it, and whoever we love and all of that is very important. But I think you need, oh my God, the one thing that I need, getting back to the MAID bill, is I think for people to understand that life is what you make it. Having a disability is not a death sentence. And with MAID is kind of encouraging people to turn it into a death sentence, because people aren't seeing enough of, just having us in the picture like they would anyone else. Like, how many times, in a movie, you just have someone who has a disability who's just playing a part, and the part doesn't have anything to do with their disability, right? Like, maybe they're like the tech person, like in one movie I saw, there's a person who was the tech person who happened to be in a wheelchair, in the van, the surveillance van, like doing, and their disability had nothing to do with the plot. They were just there. Like, you need like more of that. I think you need more of our kids going to school together. Like, are you growing up with anybody? So you see, like, how kids were, whether they walked with braces or raced around in their wheelchair or used Braille or like whatever. Like, you need that exposure as a kid, because otherwise, as an adult, if you're hiring someone, you've never seen anybody doing
Mhm.
anything like you do. Like
Yeah.
you've just not seen it. So I don't know if I've answered your question as
No, that's a
as you
great
wanted,
answer.
but I just think we need to be there. We need to be like included, like with CWO, and when one of our slides we show sort of what's this difference between integration and inclusion, right? So
Mm.
integration is like you're
You're
kind
there,
of
but you're
there.
not really. Yeah.
Yeah, you're
And
in your own
that's,
little bubble, right?
yeah. And I think like inclusion really means looking at the nuanced approaches to inclusion, like not just being physically present in a space, but really engaged in what's going on.
Yeah,
Yeah.
yeah.
Well, on that note, Tracy, I want to thank you for taking part in an interview with me today all about ableism, healthcare, MAID, and the in-between. I'm Elizabeth Mohler, and I'm with Citizens with Disabilities Ontario on the board and member at large. And I've been really lucky today to speak with Tracy Odell, who's the president of CWDO, among many other things. And thank you very much, everyone, for listening in.
Thank you, Elizabeth. Thank you
Welcome.
for coming back and join us when you can. I know you got a very busy schedule.
I'll be back.
Yeah. Okay, so I'm going to switch gears then.